I'm Dr. Len Lichtenfeld, and I'm the Interim Chief Medical and Scientific Officer for the American Cancer Society. And I'm pleased to be here today with Laura Esserman, who's actually truly one of my favorite people. Dr. Esserman is an expert in breast cancer, a breast cancer surgeon by training and experience, but certainly much more engaged than that. She's with us today to talk about a breast cancer study or a mammography study that's trying to help us understand much better which women need how much screening. I think it's a fairly simple way of trying to express what the wisdom study is trying to accomplish.
I think that's right, Len. So I think that there's so much controversy about breast cancer screening, and women are confused about when to start, how often to screen, and with what modality. And in fact, after 30 years of screening, it's definitely a time for change. We have learned so much about breast cancer treatment and so much about breast cancer biology. And now we know that breast cancer is not one disease. So it doesn't make sense for us to be approaching screening as if one size fits all, right? And so what we are saying is we need to know who's at risk for what kind of breast cancer, and how can we best target the populations that benefit most and make sure that we minimize screening for those who have less to gain where the harm might outweigh the benefits. That's really the underlying philosophy of the wisdom study, and that stands for women informed to screen depending on measures of risk. It's high time we apply the lessons about biology. We've learned so much about breast cancer risk, who's susceptible, that we think that a personalized approach is going to be the right way forward. But we aren't just doing it. We want to prove it. We think that it's so important to get out there and generate the data, generate the evidence so that women can be confident, so their physicians can be confident, and so that we set up a platform so we can keep learning and improving as we learn more.
So there are a couple of things that come through to me when you describe the study. First off, and I don't know how many people really understand this, but believe it or not, in medicine, and you know this and I know this, sometimes less is more. And sometimes more has to be done. So for some women at risk, they need more screening, or they need to have,
that's right.
You know, if that BRCA, for example, is the one most people know about. But you've also been pretty instrumental in defining groups of women who perhaps, where breast cancer, although it's clearly we lose too many women to breast cancer, and for many it's a serious disease, but for some women, breast cancer really has to be defined in a different way. You mentioned the biology. That is what the fundamental understanding of breast cancer is. And wisdom is designed to address some of those questions to help us better refine those women who need what type of screening and how often do they need it.
That's right, Len. And you know, honestly, more is not better. More is just more. Mm-hmm. For people who have more risk, more screening or more prevention may be just the right thing. But for people who have a lot less risk, or for people who are at risk for cancers that may not be on a path to kill them, more screening can simply just cause harm. This is a hard thing, I think, for people to understand. And you don't fix the people who are at highest risk of dying of breast cancer by overtreating the people who really are not at risk. And it's one of the wonderful advances in medicine is that we do understand that there's a whole spectrum of cancer types. There are some cancers that are very aggressive and are killer cancers. You know, for those actually, we are not going to screen our way into a cure because they grow very fast. There we want to focus on figuring out how to get the treatment right and to do that right up front. Then there's a group of people for whom their cancers really just are not on track to be killer cancers. And there what you want to do is make sure that you're not over-treating and causing more harm. And to me, that's one of the wonderful advances in medicine, is to be able to define that. We've actually developed molecular tools or multi-gene studies to be able to say, yes, you really are at low risk. Yes, you can have a simple excision. You don't need radiation. You know, that, and some of the in situ lesions, I think the opportunity in the next few years is to really redefine what is cancer. So things that are not on a trajectory to kill you, we don't need to screen for. You know, we don't need to overtreat. And then we can focus on that group in the middle who've got that slow growing but relentless cancers where screening is absolutely going to make a difference. And if we could figure out who the people are who have that risk, wow, what a difference we could make and how much good we could do and how much better we could apply our resources. I think that is actually the opportunity at hand. And I would say one other thing is that screening is still just screening, and you and I have talked about this a lot. I think we have an opportunity to integrate screening and prevention. When we find someone who's at higher risk, we should be making sure we understand, well, at higher risk for what? What kind of cancer? And what are the things we can start to do to prevent cancer in those women? And that is also an important part of the wisdom study. By really understanding people's risk, can we really target prevention where it might really make a difference?
Novel ideas to some of the people who are going to see this video that breast cancer is not a uniformly fatal disease, because I'm a little older than you are, but we've been around for a while. We've shared a friendship for a long time. It's almost what we call axiomatic. It's almost a fundamental truth that every breast cancer is a dangerous breast cancer. And we're coming into an era, into an age where, as you mentioned, the tools that we have, the opportunities we have to better understand the disease should help direct how we prevent it, how we detect it, and most importantly, how we treat it. Tell us a little bit about the wisdom study, because you have really been an innovator in cancer care, and mammography and the wisdom study are not the only place where you've been active in a number of arenas, and a real thought leader. You've been involved in clinical trials and redefining clinical trials, and maybe another time we'll have a chance to talk about that. But tell us a little bit about how Wisdom Trial was conceived and really how it's evolved and where we are today as we're having this conversation.
So when we were trying to think about what to do, what happens a lot in medicine is people have a good idea and they just go do it, but they don't generate the evidence to help figure out if it's really right. And what we decided was, there are a lot of people who believe that annual screening is the right thing to do. And it's not about right or wrong. It's about how do we get from where we are now to better? How do we improve? Clearly we can do better than we've done. We all buy a new cell phone every year or every other year. We demand better in our technology. We should be demanding better in our screening procedures. And so what we thought about was, well, let's test what a lot of people think is the gold standard, annual screening, and test it against a personalized approach where we would really take all of our knowledge about risk and put it to the test. So what do? We learn about people's family history. We learn about their exposures, when they start, the usual things, when people start their periods and when they had kids. But then we also add in information about breast density, which we know is a risk factor, and the genetic factors that we now know are important. In fact, there are 9 genes that can be where you can get a mutation that will very significantly increase your chance of getting breast cancer. Not just BRCA1 and 2, but there's 7 others that are common enough that they should be part of that standard. So when you're screening, perhaps the most important thing you can do is really find those people at highest risk. Now, we used to just say, oh, let's ask people all these questions and try and figure it out. But it turns out there are a lot of people who are adopted, who have small families, who don't know that much about their family history. And it turns out that a very significant number of people don't really come from families where there's a strong family history. And it turns out that a number of advances have made it possible to do genetic testing at a cost equal to that of a mammogram. We can bring it down. We can do high quality testing now, at the price of a mammogram. When we chose to partner with a group that really is doing very high quality work, and it was very committed to trying to roll it out at a cost that made it very affordable so that you could do population genetics as part of routine. So there's that, and then there's also something else. There's been a couple of decades of work where people are trying to look at individual variations. The inherited mutations are pretty rare. They make up probably 1% of the population, but an important percent of that population. An important part of that population because they're extremely high risk and you can do something to prevent lethal breast cancers. But then, you'll find families who have lots of cancer for women in their 60s, 70s. So what is that? And that actually is also probably very preventable. So it turns out you can inherit small differences in your genes, and they're a thing called SNPs, so these single nucleotide polymorphisms. And each one by themselves doesn't mean very much, but together they can actually confer a lot of risk or really lower your risk.
Well, if I may, one of the fascinating things, I'm on the Wisdom Advisory Board, and at the most recent meeting that you had out in San Francisco, I found that to be absolutely fascinating. Not only do we now understand the mutations, but these SNPs, as you refer to them, help define populations within populations. That is, a woman may have a mutation, and even within that group may have a higher or lower risk. So our science continues to evolve, and our understanding is evolving along with it.
And what's really important is we shouldn't be doing studies anymore that test this point in time, and that by the time the study's over, you're already obsolete. We know that science is moving at a rapid pace. Our trials and our studies should anticipate science and incorporate that. So we're testing the best model of risk at the time, and every 6 months we can update the model because we're testing personalized risk.
What we call an adaptive trial.
An adaptive
that is a
trial.
willingness to change the trial along the way. It's not fixed in
As
stone.
you learn. And we hope that we're going to learn and find that there might be, if we're lucky, a group of women for whom they have either no risk or maybe they're at risk for those really very low, ultra low risk tumors.
So share with us a little bit about how Wisdom got started, because it really was, lack of a better word, the force of your personality. And I say that with all good heart, from my heart. You had a vision and you decided to move it forward. How long ago was that? What happened? And in brief, where are we today, and how is that beginning to evolve? Because from where you started, you needed to get that initial funding, and then you needed to convince people, and then you needed to get others to come on board, and even recently you've had more insurers willing to say, stand up to the plate and say, yes, we think this is a good idea. Let's see what if we can contribute, if the payers can contribute as well, which has been a remarkable achievement on your part.
Well, I think, it's about making the case. It's about doing something that's compelling. So a group of us at the University of California got together and we started the Athena Breast Health Network. We wanted to come together and do something and collaborate on really trying to solve some of the big problems that none of us can solve on our own. And screening is one of those. And people are very frustrated, and there's just so much antipathy in the community, and people were fighting over things. And we decided that we wanted to move from debate to wisdom and wanted to start building a network. And the first thing we decided was, how could we start integrating screening and prevention? How could we start integrating, risk assessment at the time people came in for screening? But we realized that wasn't enough. It didn't really end the debate or stop things. So then we decided that what we would do is we would start this, adaptive trial where we worked very much with all our advocates and all our, our community members, and we have a tremendous group of women. We have over 50 women, who volunteered and are working with us as advocates, and people also want choice. So we've made the case in the study that the best way to learn is to randomize to, everyone's going to spend 35 years screening in their lifetime. So why not join a study for the first 5 to 7 years and make sure that you get the answers for yourself, for your parents, for your mothers, your sisters, your daughters, your friends. Be part, what we say to people, share your wisdom, be part of the study. Find ways, to bring what you know and your information to bear as part of a collective effort to make it better for everyone. And if you feel really strongly and you don't want to be randomized, you can join the study and you can choose. We have an observational arm. Because there's lots of, we need to have studies where we learn from everybody. So when we got this idea, we decided we were going to go do this. And I actually, Peggy O'Kane told me to submit it for Pioneer Pitch Day from Robert Wood Johnson. And we did. And I went to New York and I was in the top 3 and won a $300,000, you know, award, and they said initially, well, you can't do this study for this kind of money. You're going to need $10 million. I said, I know, but I'm going to use this as a planning grant to get it. So you still have to give it to me. And they did, and they were wonderful. And we took that and we applied to PCORI. We were the first. I mean, it's the patient-centered
Outcome Research Institute.
The Patient-Centered Outcomes Research Institute.
For those who are watching, that's a government agency that was set up to do trials to find the best evidence in how we care for our patients.
That's right, and we were so lucky that this came to be right around this time, and saying, look, we need practical, big studies to really answer these important questions that really matter to huge numbers of the population. Of course, this is, you know, all women will face this question: should I screen? When should I screen? You know, how often should I screen, and with what modality, and when should I think about prevention? So that was the case we made, and we won the first, you know, pragmatic trial award. We partnered with Salesforce to really build the website. Everything's done electronically. But PCORI had a stipulation. They said we had to get an answer in 5 years. We had to have something that could be ready, shovel ready to be implemented in the population, and we had to partner with payers to help cover the studies that were part of the personalized arm. And I actually thought it was a great challenge and an important one, because that's actually what will make the difference. I mean, we do these big studies and then we spend a decade arguing over them and we don't really implement them. I think that's unacceptable, and I think you do too. And so I tried to set this up differently. So all the stakeholders are at the table. So the time to argue about the studies is now, before the data comes out, and get everyone at the table. And we've invited all of the payers to the table. Now, who have stepped up is first Blue Shield of California, who created a coverage with evidence development policy for us, and then Blue Cross Blue Shield Association National has now stepped up.
The university also stepped up to the plate too, University of California.
Oh yes, absolutely. So the University of California has absolutely allowed us to start this whole network, and we actually have created this infrastructure that allows us to, to organize and work with the payers. So we are able to implement a system where we can use the payments to build the infrastructure and make it so that when you go to implement it, I mean, if it turns out that it works, we've built in what we think it will truly cost to roll it out. And I think it's something we should really think about going forward. And I would be interested in what you think about this, Len. You know, we are one of the few countries that does what we call opportunistic screening. We don't have an organized, structured program like Sweden or, you know, areas, people in Scandinavia, the Netherlands, you know, France, the UK. You know, we you know, if we had the platform like this, we could really continue to learn and grow. I think it's so important for us to think about this. You know, this idea of testing personalized versus annual screening is the first step. If it turns out, you know, what are we trying to ask? Is it as safe? Is it less morbid? Do we do fewer procedures for the same good outcome? Is it preferred by women? You know, are we able to promote prevention because people realize they're at risk and they have something to gain? You know, and are we actually encouraging more people to come up with cool new ideas for prevention studies, which is already happening. We've got 2 new exciting ideas, and we're finding new and better ways to screen women with dense breasts. I mean, that's really exciting. And then at the end of the day, you want to ask, is this healthcare value? PCORI was actually set up for that. It's part of the, you know, it was established with the Affordable Care Act. And part of it is that, you know, if those of us who are physician leaders, we have to think about what's the best way to spend our resources? How do we get the most good and cause the least harm to people and make sure that our dollars go as far as they can?
Well, I want to emphasize something here that I think is important, and people may be asking themselves this question, because they've heard a lot about, oh, you don't need to do this, you don't need to do that, you know, whatever. And there are a lot of folks who feel that that's just a way of not giving care, period. There are various words that float around, and one of the current one, for example, value-based medicine.
Right.
And value-based medicine to you and me means making sure the person gets the right care at the right time and has access to the care they need, no matter, sometimes it's not expensive and sometimes unfortunately it's very expensive, but we want to make sure people have access. And so when we talk about how we use our resources, what we're really saying is we want to be as effective as we possibly can and cause the least harm and inconvenience that we can. Because we talk something about like mammography. You know, there are women who have to take a day off from work to go get a mammogram, or if they have a follow-up, they have to go through all of that. And the convenience factor unfortunately, is not there. But we want to make sure people have access and they get the care they need, not cutting back care, not denying care.
That's
making sure that we have better science today than we've ever had before. You've talked about what it was like in the 1980s. I can share some time before that, before mammography even showed up on and we did believe. We believed strongly and that if we could find every cancer early, no matter what it was, every cancer early, we would save every life. And that turned out, unfortunately, because of the biology, not to be the case.
It's more complicated.
But today the care is expensive. Health insurance is expensive.
Right.
But it's important we figure out what the right care is and the best care, and that's what this trial is all about.
That is our responsibility. Yeah. And I'm going to give you a couple of examples because I think people need to understand that, over-treatment and, over-intervention has a cost.
Too much care.
Too much care is not good is a problem.
Right.
So if people screen for 10 years, they have a 50% chance of getting a false positive, meaning they would be called back for a biopsy or called back for something and get a biopsy. Biopsies are really stressful. They really frighten people. When people have one or two of these experiences, they tend not to want to come back and get screened. So we're actually shooting ourselves in the foot. I saw someone last week who had had 7 biopsies in the last 8 years, and she was coming in and asking if she should have a prophylactic mastectomy. I mean, that's terrible that you would drive people to the idea that they're so frightened and they keep thinking that something is wrong, or you keep biopsying until you find something. We don't want to do that. That's not helping somebody. I've been taking care of women for over 30 years, and no one can say I'm not devoted to improving our treatments for breast cancer or trying to save women's lives. But I know that by over-treating someone who has something that's not going to kill them, I am not helping the person whose life is at risk. And so I think it is just as wonderful to be able to say to someone, oh, you know what? This is not a cancer that's going to kill you. And we actually have the technology and the ability to say that. Oh my gosh, it's like you're taking this whole weight off someone, and they're not just waiting for the other shoe to drop, or they don't come in and say, oh, I'm going to take both my breasts off. And there is no such thing. I'm a surgeon. I know this. There is no such thing as a medical intervention that doesn't have a complication associated with it. So we want to use our techniques where they help people, but we don't want to use them where they don't. I don't know if we're going to be able to find a group of people for whom their risk is so low that it would make sense to say, you don't need to be screened, or maybe you only need to be screened every 5 years. We figured out how to do it for colon cancer. How fabulous would that be? I don't actually know anyone who loves getting their mammograms, but they'll do it because they think it's going to help them. If we could find a group of people for whom it isn't very helpful, how fantastic.
Well,
and if we could find a group of people for whom it matters so much, instead of having 60 or 65% of those people screening, we could have 100% of those people screening. Now that's value. That's what we want to do. And we want to have, we want to work in partnership with with people in the payer community. And in fact, I am so grateful to Blue Cross Blue Shield for stepping up.
And I want to make another point, if I can elaborate on that, because you talked about that earlier. You mentioned the words coverage with evidence, and most of the folks probably don't know what that means. And what that fundamentally means is the payer, the insurer says, and Medicare in some cases, not here yet, but insurers will say, we know there's a question being asked here, an investigational question. We're willing to pay for the care because the care aligns with what is the best care that's available, maybe with some additional things involved, but we're going to help pay for that so we get a better answer for how we care for the patients and what the appropriate treatments are. Coverage with evidence is not something that's baked into the cake for the commercial payers, for the people, the typical private insurers. And the fact that you've been able to get, initially Blue Cross and Blue Shield of California came on board, the university came on board, and now National Blue Cross and Blue Shield has stepped up to the plate, and they have several of their affiliated plans are willing to do it. I think that's pretty remarkable. We have a tendency, and one of the examples that I use is we have done a lot of treatments to a lot of people over many years, and prostate cancer screening comes to mind, where we walked down the path of saying, yes, it works, we assumed that it worked, we treated a lot of men, we saved some lives, we harmed many others who probably didn't need to get aggressive treatment, and now almost essentially everybody's on board with understanding what the role of prostate cancer screening is, what we would call watchful waiting for, it may not be the best word, but the point is we don't have to treat every man where we find prostate cancer, and some men we must treat very aggressively. The payers can help make this happen. Absolutely. By committing to this concept of what we're talking about here today with wisdom. Blue Cross plans have, and I certainly hope, and I know you do as well, you've been very active in trying to engage them. Hopefully others will step up as well to say,
they should.
This is a relatively minor cost for a huge gain in our knowledge.
Well, you know, I think it's very interesting. The first, really the first groups to step up were the self-insured employers, because actually, it turns out that when you're smarter about how you apply your resources, it actually helps everyone you're taking care of. It makes your employees happier, you give better care, and your healthcare dollars go farther.
Yes.
And University of California, UC Health, was the first to step up. Salesforce, Genentech, Qualcomm. We're actually working with Inland Empire and Valley Healthcare, and you know, a number of other employees are now stepping up. And then, you know, because they realize this makes a difference. And I think we all have to ask ourselves this question. We've always said there's care and there's research, and they should be absolutely separated. But I actually don't believe that. I mean, the reason why we have a tech industry, the reason why we have innovation is because we're constantly learning. Our patients expect us to be learning from everyone we take care of, and we don't have that infrastructure in place. That is my fundamental hope, is that we change care so that care tomorrow is better than it is today.
Yeah, you know, every one of those companies you mentioned has been an innovator company, you know, on that list. And there are many others out there. And when you mentioned self-insure, that means that they fundamentally may hire an insurance company to manage the claims, but they make the decision what they're going to cover and what they're not going to cover. But every one of those companies has survived in business because they're innovators and thinking differently. And maybe the message out of this is that they have to start thinking differently in terms of better ways of caring for patients and helping being part of the solution, as opposed to saying just say no or whatever.
Right, and why are we fighting? We are spending all this time fighting with each other, and we're not making it better.
Well,
what we need to do is partner and say, let's generate the evidence and the data that allows us to do better.
On that note, I just want to say thank you so much for being with me today here at the American Cancer Society, and even much more important than that, for everything you have done for women and others throughout the world. I mean, I said it at the beginning, you're an innovative thinker, you're somebody who I admire a great deal. We don't have time to go through the long list of accolades that you've received, but your commitment to this trial and trying to find a better way and a question that really, yes, does revolve around data, that sometimes it gets refreshed and sometimes there are new studies, and even up till recently there are new studies coming out talking about the value of mammography. We don't certainly want women to understand that mammography is still a very important part of their total health care. But moving forward and trying to find some of the answers is so critically important, and that's why we're here today.
We invite everyone to join Wisdom and share their wisdom and make the future better,
And so,
starting today.
So if they want more information, they can go to the web and
Wisdomstudy.org.
wisdomstudy.org.
That's right.
And it's there, and they can find out more about the study, and also if they're in a location where they may have the opportunity to actually participate.
That's right. We're actually, moving this all over the country. Go to the website and see if your city is, in your community is one that's participating. If not, bug your insurer and tell them that they should be participating. We actually hope that we'll make this a platform for screening and prevention across all cancers, and I really look forward to continuing to work with you, Len. You've been fantastic, and thanks so much for having me.
Well, it's been a real pleasure. I'm Dr. Len Lichtenfeld with the American Cancer Society. Thank you.